My name is Bradley Albertson, and I am a graduate of the orthodontics program at the University of the Pacific Arthur A. Dugoni School of Dentistry, and I will be presenting a case that I treated while in residency. A 15-year, 8-month-old Hispanic male presented to the orthodontics clinic with the chief concern of wanting to straighten his teeth. He reported trauma to his upper left one approximately 1 year and 6 months earlier, and root canal treatment had been completed on this tooth. The initial extraoral exam showed a convex profile with an obtuse nasolabial angle, with upper and lower lips retruded relative to the E line. The intraoral photos and initial models showed moderate maxillary and mild mandibular crowding with a full cusp class 2 molar relationship bilaterally and class 2 canine relationship on the left. A deep impinging bite was present with an overbite of 5.7 millimeters. An overjet of 6.8 millimeters was measured from the protruded upper left one. The upper right 3 was labially impacted, and the initial CBCT showed the position of the tooth labial to the root of the upper right 2. No root damage to the upper right 2 was noted. A sagittal section of the CBCT was created to assess the upper left 1. This section view of the CBCT showed extruded gutta percha facial to the upper left 1 with a surrounding radial lucency buccal to the root. The tooth was asymptomatic and negative to percussion testing. Given the history of trauma to this tooth, the potential for ankylosis was noted. Cephalometric analysis revealed a mild class 2 skeletal pattern with an A and B of 3.5 degrees and a hypodivergent growth pattern with an FMA of 18.7 degrees. The maxillary incisors were upright with an upper 1 to SN of 91.3 degrees, and the mandibular incisors were well positioned with an IMPA of 89.4 degrees. The treatment options were as follows. The first option included endodontic consultation concerning the prognosis of the upper left 1, exposure and bonding of the upper right 3, placement of bite turbos and vertical posterior elastics for deep bite correction, use of forces for class 2 correction, and restoration of the upper left 1 to match the height of the adjacent teeth. The second option included endodontic consultation concerning the prognosis of the upper left 1, extraction of upper 4s and lower 5s with reciprocal space closure and class 2 elastics to correct the class 2 molar relationship, observation of the upper right 3 for eruption with exposure and bonding as necessary, use of a lower intrusion arch or arch wire with reverse curve of SPE for deep bite correction, and extraction or decoronation of the upper left 1 in preparation for a dental implant. The third option included endodontic consultation concerning the prognosis of the upper left 1, extraction of the upper 4s to finish with class 2 molar relationship, observation of the upper right 3 for eruption with exposure and bonding as necessary, and use of a lower intrusion arch or arch wire with reverse curve of SPE for deep bite correction, and extraction or decoronation of the upper left 1 in preparation for a dental implant. If you are interested to see how this case was treated, please go to the PCSO Bulletin 2019 Spring Edition for more information.